Okay, so welcome to the Samsung sponsored presentation of scapular dyskinesis. This is a condensed version of a full-day workshop at Interventional Orthobiologic Foundation presentation workshop in 2020, right before the pandemic hit. It was a fantastic workshop. It was a full day. It was like 3 hours of didactics and cadavers and injections and lots of ultrasound and an all-star cast of great clinicians, and we had a blast. And so this talk is trying to condense a full day into an hour. I'm going to try to get as much of that covered. This talk should be about 55 minutes, and then I'll stay as long as there's questions. And then a special thanks to Samsung. They've been amazing support for me over the years. I call up Samsung at a drop of a hat when I need 2 more machines because we have more registrations than we have machines available. And I say, I need some high quality cart-based systems. We're doing brachial plexus stuff, and they always say yes, and they always get me machines. And so I don't know how many of you out there have tried to get or organize conferences and organize workshops or cadavers or whatever, and getting high quality machines is critical for advancing musculoskeletal ultrasound in the United States. And so, I really appreciate the opportunity to give this talk, and special thanks for them for being such a willing participant and helping out for many of the talks I've provided. So our objective today is really about a short intro on key physical exam findings. You need to know how to examine the scapula. And then once you've sort of established a hypothesis, then a specialized musculoskeletal exam for the scapula. And so I will sort of show you a protocol. We all have a protocol to scan the shoulder and the elbow, but there's really not much written in terms of how to scan the scapula. We'll talk about basic MSK ultrasound concepts in terms of the fascial exam. That's normally a full 1-hour presentation, and we're just going to give you about 15-20 minutes of that. And then a very, very advanced neurologic component. Realize that if you have a cart-based system, a laptop in your clinical practice, you may not be able to perform some of these things, but I want to throw the bar out there on what's possible, what you're able to see with enough practice and an advancing skill level. So the major risk factors for scapular dyskinesis in my clinical practice, I'm here in Helena, Montana, and people travel from all over the United States to see me for scapular dyskinesis. I just had a woman from Arkansas yesterday here. Her injury was a direct trauma. She fell off a horse and woke up with a head and neck and shoulder injury. And so that's the most common thing I see, sort of that direct trauma to the shoulder. But certainly neck injuries, overuse fatigue, intense repetitive overactive activity. I see a lot of weightlifters that injure their scapula and shoulders through a repetitive exercise. Neurologic injury, there's lots of different risk factors. Signs and symptoms that are most common in terms of my practice is that drooped, anterior rotated, affected shoulder. There can be atrophy. Subtle weakness may be present, and if you're only screening for just quick onset strength, you're going to miss out the shoulders that have fatigability. Realize that the rhomboids will fatigue and start to wing later in exercise. Certainly a scapular winging, medial border elevation. Lots of these patients have hitches and jumps where the scapula is bouncing along the ribs as you try to move the scapula through motion. And then that burning scapula pain syndrome, that is the main thing that I see. That pain is just gnawing. It's 24/7. It never goes away. And that's what brings people to Helena, Montana for treatment. The differential diagnosis is extensive. For our purposes today, you have ruled out rotator cuff tear, something going on with the rotator cuff, labral tear, bicep subluxation, impingement, ligament sprains, multidirectional instability of the shoulder. Those things should have all been ruled out. Likewise, most of the patients have had a cervical workup. They've had an MRI of their neck, and nobody sees much. Unfortunately, a lot of my patients have all had neck surgery, did not help their symptoms. As they were thought that a bulge or a small compression was thought to be causing their pain. So we'll talk a lot about some of these fascial components and hyperlaxity syndromes as we move forward in this talk. There are some structural issues you need to be aware of. Certainly thoracic kyphosis can be an issue. If you have a shortened or non-union clavicle fracture, that can create a scapular dyskinesis. AC joint or SC joint instability or arthritis, and then glenohumeral arthritis are all common structural issues that should have been ruled out before you embark on this pathway of scapular dyskinesis workup. So the soft tissue issues, certainly the hypermobility, hyperflexible person, pectoralis minor tightness or shortening through too much anterior weight workouts, certainly posterior shoulder instability, and that patient that's had a previous contracture through either adhesive capsulitis or previous surgery can all be a part of scapular dyskinesis. So once you've kind of established that you're just going to focus on the scapula, not sure why that's sounding. So what you're going to want to have a functional exam that brings them through forward flexion and abduction with the shirt off and be able to evaluate the scapula accurately. I'll do a lot of looking for inferior medial border prominence, early scapular elevation, rapid downward rotation with descent, and a mixed pattern. And so once you've sort of keyed into what type, we'll spend more time talking about those patterns, but the neurogenic causes, you need to look for C5 variations, superior trunk entrapment, dorsal scap nerves, a big common cause of shoulder dyskinesis, long thoracic, and spinal accessory to the main culprits. And we'll spend time with that, but the brief take-home message is here is there's a neurogenic component as well as a muscular component. So this is where I like to sort of step back and say, you know, you have to decide what is the effect and what's the cause. And so I like this image of the broken bicycle wheel. So if you're riding down a steep mountain pass, you're going pretty fast, a spoke is broken, and all of a sudden your wheel starts wobbling and you lose control and you go into a ditch. And now you have lots of broken spokes. Well, which one of these spokes was the culprit that led you to the crash? And that's your job in scapular dyskinesis. Not only treat the effect of having this one broken spoke, but also identify what that spoke was. And so your history of what happened, the trauma, where the initial pain was, where the initial problems were, are very key in terms of your history and part of your physical exam. I'm not going to spend a lot of time talking about the different scapular movement patterns that's well reviewed in the literature, anterior and posterior, but it's important to understand elevation, retraction, protraction, all the different movement planes and what's most active during that. And so you're going to want to get a history that looks where they have the most scapular pain. Is it with reaching forward? Is it an abduction? Is it reaching back? Retraction, protraction of the scapula. And once you have those historical findings, you're ready to begin your scapular examination. So what's important in my clinical practice is you need a systematic, reproducible exam that you can document the degree of dysfunction. Because what happens is they come back a couple months later and say, well, I think I'm a little better, but I still have some pain. And they're looking for the miracle cure when they come and see me. What I like to do is show them that here's your old video clip or your hold images. Here's what your scapula looked like before. And by doing serial imaging, we can show them that we're seeing improvement in the scapular winging pattern and overall improvement of function because the pain is the last thing that goes away. Function improves first and then pain will resolve. So the basics really are about scapular motion. That's the key to your examination. You'll see that I drew lots of drawings on my patients, and this drawing here is in neutral, abduction, and forward flexion. This is pretty normal. This is what you should see. If your arm is below 90 degrees of abduction or forward flexion, these lines should merge. Right here, I already have a diagnosis in mind based on this line. I have lateralization of the scapula in abduction. And so depending on if it's an abduction or forward flexion, you have different pathology. And again, it's a neurofascial muscular examination, and your dynamic ultrasound is an essential part of your scanning protocol as well. So your focused scapular, focused scapular exam is really, taking some images at rest, check for atrophy, maybe draw some lines on them in terms of what the position of the shoulders are. You may want to measure from the spinous process over to the spine of the scapula, superior medial border, and the inferior medial, the inferior angle. And these measurements are what you use at follow-up visits to sort of show the patients they're making significant improvement with physical therapy or the treatment plan you've outlined, or with regenerative medicine. This is all really critical. So once you've accomplished that, then you start looking for the main type of scapular prominence. From a historical perspective, I like to at least talk about, because many of us work in orthopedic offices. I have my own private practice, but Keebler was sort of the first person to describe these three main type of patterns. I disagree with his hypothesis of why they're occurring in most patients, but I think it's important historically to look at this sort of inferior medial border scapular prominence. That's probably the most common thing that you'll see. This sort of full medial border elevation or prominence. And typically that's thought to be from trapezial fatigue or rhomboid weakness, but we'll explain why that's not necessarily the case. And then historically, he talks a lot about superior prominence and the medial border. And he believes that this is mostly related to impingement or rotator cuff injury. And I'll also talk about why that may or may not be the case. But, again, if you see this, you want to take special attention to the rotator cuff and look for other impingement etiologies. And then you need to have a sophisticated neurologic exam. And we'll spend quite a bit of time on the sonographic component of the neurologic exam, but we're really focusing on the suprascapular nerve, spinal accessory, long thoracic, and dorsal scapular nerve. And you want to be able to examine the shoulder and scapular movement patterns with forward flexion, abduction, looking particularly for certain motions. And again, you may want to check these with scapular motion. So this is a patient evaluation. Here's resting, and then this was resting on the opposite side. And just this image, I know that this patient has a spinal accessory nerve issue just by the picture itself. And then here's with abduction, and then you'll want to look at different motion patterns and start making your marks. You can come up with solid lines, different color lines, whatever, but documentation with pictures of this is critical for an accurate diagnosis and examination. So here's an example of a long thoracic nerve. You have that classic inferior angle winging with forward flexion descent. So during the descent, you see this big winging pattern. With dorsal scapular nerve, you're going to see lateralization. So see, these lines are merged with forward flexion. You'll see lateralization with medial border elevation with forward flexion. So the whole medial border with forward flexion will be elevated. If it's a mixed pattern, you'll see elevation also with abduction. And then the rotational abnormality is most common seen with spinal accessory nerve or winging with abduction. So if you see this wing with abduction, that's a spinal accessory nerve problem. If you see sort of this, as they come down from abduction, you see all of a sudden the scapula just loses complete control of this nice orderly descent, and then it has this rapid rotational abnormality that's consistent with usually some spinal accessory nerve involvement. So both of those parts of your scan are really critical. And remember that you may, after you've done your forward flexion abduction, do side bend or rotation of the neck just to make sure you don't see a different or a change in the winging pattern, which may suggest you need to spend more time in the cervical spine. There's some classic stuff described by Keebler. I typically use this test as a test for muscular strength. So what I'm doing is I'm stabilizing the scapula. I'll test their strength without my arm, my hand on their scapula. And the patient he's not as strong. He can't really resist me as well. And some people will completely collapse. And then I'll put my hand here, and then I'll do the same test looking for whether or not I see improvement in strength. So that tells you that you're truly dealing with a scapular issue in terms of stability to push off of. There's lots of special tests described. I do this a fair amount with the arms in neutral and then on hips, and then make the measurements from an abduction, looking for those scapular motions. You can just do video clips or make the drawings on the back. All of those things work to give you enough information so when they come back and you can reevaluate if your treatment plan is working. That's the critical element. Can you reproduce the examination findings? This is a really important piece. It's kind of the last thing I do in terms of the physical exam, in terms of functionality measurements. I lay them down and I measure both sides to the anterior portion of the acromion. I'll measure that because if you're improving rhomboid function and shoulder retraction capability, this will start to diminish as the rhomboids start to fire better and work better. Then finally, the last and most important part of my exam is I'll lay them face down. I'm going to push, they actually lift this arm off the table, and I try to push it down, and I'll test without any assistance, and then I'll just with about 1 or 2 pounds of pressure with this finger right here, I'm pulling on the latissimus dorsi and just pulling it down, assisting it with just 1 or 2 pounds of pressure. And if you see improvement in this, then you want to pay special attention to latissimus dorsi during your ultrasound evaluation. Here I'm taking my finger and I'm pulling in the direction of the rhomboid major. And so I'm just taking a little bit of pressure, pushing this way and testing for muscle strength. So in this patient, they had no improvement in their strength. I went up to the rhomboid minor, a little better. I went up to the levator scap. I did the latissimus dorsi. I did the serratus anterior. I'll do those and push on different positions. So here's an example of a different technique. I'm using the same thing. I'm going to assist rhomboid minor, which is a little bit of pressure, and the dramatic improvement in the strength. So here I am again, and the arm's weak, and I just assist the serratus anterior a little bit, and wow, way stronger. And so I know that this inferior medial border has some tendinous issues in terms of what's happening here in terms of their normal movement of the scapula. Here's another technique that you can utilize. I'm just going to take and I'm going to push on the serratus anterior. I'm going to pull in the direction of its contraction and test for muscle strength. And so you can see that waning pattern. I just assist it just slightly and test again. The disadvantage of this test is it takes 2 people. This is a patient that's had surgery, no improvement. You can see this really prominent medial border with forward flexion, and as she comes down, you can see that prominence there. So we're looking for kind of a mixed disorder in terms of what's happened with this patient. So now that you've completed the physical exam, what's important to realize is your history and physical should lead you to a hypothesis of what the pain generator is in terms of scapular dyskinesia. You should try to, put that thought in your head. Don't go to scan that first, but your goal of your ultrasound evaluation is to confirm that suspected diagnosis. And so you want to run through your protocol and then maybe go back and spend additional time at your hypothesis to make sure that you didn't miss something. And it's really important that you have both a neurogenic, muscular, and tendinous component to your evaluation. And we'll talk about the fascial component, which is the most fascinating part to me. So you should have a protocol that you develop that that all of this stuff's been done. So the shoulder's been evaluated, AC joint, SC joint, that's all been completed. You've ruled them out. And then you should have this thorough, comprehensive evaluation. And you may want to take a screenshot of this right now so that you have my protocol. This is my protocol. You can come up with whatever protocol you want, but this is how I go through a systematic approach to the muscular component and some of the nerve component. So the supraspinatus fossa exam. So what I'm going to do, and what's critical, is you need to be able to find approximately the same place based on the floor of this, because if the scapula is lateralized, if you measure over from the spinous process, you'll be in a different place. And so it's important to be able to find sort of a landmark that you're looking for in terms of the floor of this fossa, so you can make an accurate measurement of the supraspinatus. You can clearly see there's asymmetry in terms of the muscle development. So right now, just based off this first image, I know, ooh, I need to spend a little more time with the suprascapular nerve and my neurologic component. And in this patient, you can clearly see infraspinatus on the left and the right, and you need to be good using your left and right keys so you can do side-to-side comparisons. And you can see all this muscular change here. This is fatty infiltration, atrophy. This muscle is not healthy. And if you've ruled out a rotator cuff tear to the infraspinatus and teres minor, you know there's a neurogenic component and you need to address that. Likewise, you need to be accurate in terms of being able to find a point on this scan. So you'll find, and the way I scan this is I'll slide laterally, and the straightest anterior will emerge over the top of the rib. And then as you slide back, levator scap will emerge underneath, and you'll scan back and forth, levator scap, straightest anterior, levator scap. And then when you get into the straightest and tap, you want to be able to find approximately the same position so you can look at trapezius muscle development and levator scap muscle development. This is a healthy levator scap. I don't need to spend a ton of time looking at the dorsal scapular nerve, or as we'll talk about later, that nerve can come from C3 and 4, but I know I don't need to spend a ton of time in looking for the neurologic component. Then I'm going to switch sort of axial to the skeleton. I'm sort of right over the superior medial border of the scapula right here. This is trap. This is this skin, medial on both sides. Here's lateral. And this, whoops, this fascial plane right here is packed with spinal accessory nerve fibers. And so this is for many patients what creates that burning scapular syndrome. And you want to take a picture at the superior medial border of the scapula, the spine of the scapula, and the inferior medial border of the scapula, so that you have an idea what side-to-side comparison is of trap, rhomboids, and other structures. And then once you've completed that part, I go back up to the superior medial border and do what I call as a windshield wiper test. And this test is to look for whether they have this punched out lesion. So here I am going with forward flexion and abduction. The timing of these two aren't the same, but you can see that the scapula with movement is punching a huge hole in this fascial layer. And these are all spinal accessory nerve fibers. And for many patients, this is what's creating that burning scapular pain syndrome. So the question is, you can't solve this problem if you don't get rid of why the scapula is punching through here, but their pain's coming from the spinal accessory nerve. Once you've completed that component of your functional examination of that superior angle, I'll find the superior medial border of the scapula. I'll anchor my probe right here, and I'm slowly going to get levator scap lined up and trap. And I'm slowly going to dial the top portion towards angling towards about C4, C3, or C5. And you'll end up getting this long levator scap in long axis. And that's the key to this portion of the exam. So here we are, trap. I've got this in long axis now. Here's rib. This is the angle of the scapula right here and right here. And you're going to be able to look for asymmetry in muscle development and look for little hidden injuries or tendinopathy in area of tendon tears at this border. Now, the key to see that is what I call the look back technique. This is a technique that I developed to try to see underneath the scapula here. So what I'll do is once I'm in long axis, I'll tip the probe anteriorly, so I'm looking back underneath the scapula. And so you get a nice clear image of this insertion from the underneath surface. Now, what's important to realize is this is a conjoined tendon of the serratus anterior, levator scap, and rhomboid minor. This all is a conjoined component. So you have to look at all three components here, but this is sort of the axis I'm looking at. It's pointed to about C4, and I'm in long axis to the levator scap heading up. And so this is the key element for this part of the exam. And this is the area where most of these patients say they have pain. And so here we are looking, using the look back technique. I'm looking and I see this little bony fleck here. I see disorganization of the fibers under here. Some of that's because of acoustic shadowing, but this area is difficult to see because there's a bony fleck that's been pulled off. And this is some disorganized fibers here. This is the second rib. And so you want to be able to master this technique. So, and this is a young athlete where they've actually pulled the tendon away from the bone just slightly. You can see the neovessels take off, and you can confirm the pain. This is a pain generator by putting a little 0.2% lidocaine in here, like a half a cc. And if the pain goes away, you have a confirmed diagnosis. So this look back technique is critical in terms of evaluating that levator scapula insertion. And then I'm going to slide laterally. So if I slide medially, I'm going to pick up the levator scap. I slide laterally, I'm going to pick up the branched from the first rib to the superior angle. So this is it. This is the superior angle right here. This is posterior, this is anterior, and I'm going to measure the thickness of the serratus anterior. And if you see atrophy of this, there's a very specific nerve that you need to be identifying. We'll talk about that later, but it's called the R1 branch, or the posterior branch of the serratus anterior. So this is a critical element, and you need to be able to kind of compare apples to apples and find the same location. Now, here's my look back technique. Looking at the superior medial border, I can see irregularities into this insertion. It doesn't look healthy, and I'm concerned about this area being normal. Now, there's a wide range of normal, but here's that first rib serratus anterior. Now, these apps that you pick up that we use on our iPads and our phones do not do justice to the size of this muscle. This muscle can be quite large and is appears almost as big as the levator scap in many of these images. But you want to be able to look back into this area and identify irregularities at the insertion. And so here's a left-right comparison, disorganized, lots of little micro fragments. This thing's just a mess. This side, this is more what you should typically see in an older athlete. This isn't a young teenager for sure. But these are all important aspects of your technique. So here we are, look back technique, there's an avulsion fragment off of this side. So you need to compare apples to apples and compare both sides. But that scan, looking back at this, is an essential element. And you're going to need to practice this. It's not going to be the first time you get in there, you're like, well, I can't quite get it. You're going to need to practice it, and you get better and better. And so if you can find the superior angle on axial plane, then slowly change your proposition so that you keep that highlighted. Once I've completed that, I'm going to run down the whole length of the scapula. Frequently, it'll be a video clip, and I'm looking for changes from side to side on rhomboid major. These two are not equal. So traps are normal and healthy, but the rhomboid major is a problem. And then as I'm going down, keep special attention to the fascial thickness. If you have inferior medial border winging, you'll have a fascial thickening that's causing pain. And so you need to document the thickness of this fascia so that you can follow that up later on in terms of recovery. And then finally, kind of the last couple muscles that you need to scan in terms of your normal protocol is the serratus anterior insertion to the inferior medial border. So I'll put the person in about an arm position. They're on their line on their side, 120 degrees, 110 degrees of forward flexion. And I'll look back towards this. I'll follow these serratus anterior insertions here. Don't get confused with teres major, but you want to be able to compare the two sides. You can clearly see atrophy on one side, and just the tendon does not appear similar. You want to check for bony erosions, avulsions, all kinds of injuries can occur at the serratus anterior. And if you see an abnormality where the muscle doesn't look healthy, you need to follow that muscle to the rib slip attachment. So those are all important elements. And then finally, the latissimus dorsi. So what's interesting is about 30% of people have a direct attachment of latissimus dorsi to the scapula. And so anybody that's presenting with inferior medial border pain symptoms, you want to look for this direct attachment. So I'll start my scan clear up here by the shoulder, identify the latissimus dorsi, and follow it all the way down. So here I am. This is all latissimus dorsi. This is scapula kind of forming. This is the bulk of the latissimus dorsi forming and coming over, but this is that direct attachment. Realize the other two types are no attachment at all or indirect. But for my practice, this is what I see the most common in people with scapular pain issues. So once you've completed your scapular muscular tendinous exam, it's important that you did side-to-side comparisons, use look-back technique. And to learn this, I mean, you're just like, gosh, I don't have time to learn this in my clinical practice. What I did is every week, every time I did a shoulder exam, I would focus on one part of this. So maybe one week I'd do the look-back technique to the levator scap. The next week, everybody got a serratus anterior look-back. Next week, everybody got something else. And so you just add this to your normal scanning protocol for shoulder, and pretty soon, all of a sudden, you get more comfortable with all the elements, and you get to look at what normal is so that you can identify what's pathologic. So the fascial component, I'm going to just jump right in. This is the area that I think that I'm the most excited about. It's hugely important in terms of normal scapular function. And again, we spent several hours on this in our workshop. So this is my scanning protocol for the scapular dyskinesis and the fascial component. You might take a screenshot of this so you have it for later, or this talk will be apparently is going to be available for review as well. I also included my neurologic protocol as part of this. So what's important to understand is muscles rarely exert their entire force or transmit their full force directly from a tendon to the skeleton. The fascia is involved and heavily involved in scapular motion. So there's this concept of biotensegrity, which is a model of movement that requires pre-tension. And we're going to talk about pre-tensioning of this scapular system as a way to control muscle movement and strength. So what's important is every muscle action is a result of cooperation of all the neighboring muscles. And it's the fascia that allows that communication because the fascia has a pre-tension built into it. So the easiest way to explain this is, so if I have just a bunch of tent poles and I stick them up, I don't have anything. You can push it right over. I lay a tarp over it, I still don't have anything. They'll just fall over. But if I stake it out with tension, I have a structure. Now, what if I pull one of these tick stains out? My tent is still no longer a very good structure. So fascia actually surrounds all muscles, tendons, ligaments, bones, neurovascular system. It surrounds everything. And what's interesting is the fascia is the main way that proprioception communicates with muscles surrounding that area. And they use that with pre-tension. So if I go to this tent and I just tweak this cord right here, this whole tent feels that instantaneously. So what's more probable that a small tweak here is communicated all the way around all the muscles and tendons and ligaments in the skeleton, or the signal goes all the way to the brain and back down to tell you what next to do. So there's this pre-built-in pre-tension system that coordinates movement of the scapula and the rest of the body. And it's the pre-stress of that fascia that allows for this normal muscle movement, coordination, activity, stabilization. So the tensegrity model is these sculptures that we all have kid toys that use this, but all these cables allow this structure to go hundreds of feet in the air, and it looks improbable that it can stand. But what's happened is the pre-tension of the system suspends this entire system. Just like the pre-tension of the fascia in the shoulder is allowing the suspension of the muscular tendinous system of the shoulder. So pre-stress is required to initiate motion and normal movement. And that's true in the spine, and pre-tension loss in the spine also results in instability of the spine. So all of this is required in the biotensegrity model. What's important to know, though, is that fascia is heavily innervated with nociceptive and proprioceptive fibers. And so here's our ultrasound. We've seen some fascial examples already, but fascia is multi-directional in terms of its fiber alignment. So no matter what plane you move your probe, it's going to be hyperechoic. Unlike tendon, unlike traps, you're not going to have that hypoechoic signal change when you change direction of your tendon. So this interconnected fiber network is essential for developing pre-stress. What's important is that the fibroblasts create some ability to contract. So these myofibroblasts actually create tension within the system by contracting. And so people with hyperlaxity syndromes have loss of normal communication of the muscular component of the shoulder. So this is a picture of fascia with the nerve endings in it. So they're packed with nerve endings. And if you stick a needle into fascia, many people will have radicular pain. So if you stick a needle in the fascia above the superior angle of the scapula, and a lot of my patients, they'll say, I felt that all the way down to my hand. There's no wiring diagram that supports that in terms of what we know from a neurologic standpoint, but I see it all the time. This fascia is packed with mechanical receptors, nociceptors, and it's critical in terms of normal function of the shoulder. And anytime I inject the fascia, they frequently describe a burning, throbbing, or stinging pain. And so this entire system is part of the pain syndrome associated with poor scapular motion. The other thing that's important is fascial planes have to glide over each other, and fascia secretes hyaluronic acid. And dehydration of those fascial layers from overuse and rubbing or friction of those layers with repetitive overuse creates adhesions. And what's important to realize is that stiffness pain that people with arthritis have at the first thing in the morning is that fascia isn't gliding. And so notice that it's killing them for the first 20 steps, but once they get that fascia gliding, they start to develop normal motion and their pain gets better for part of the day. So that's the fascial component of the knee or other movements. So here we are. So how do we scan this to learn what the heck is normal gliding pattern? And so I started years ago sort of scanning fascia, looking at normal gliding. In the beginning, I didn't know what in the heck I was looking at, but over time, reading lots of articles, reviewing literature, looking at different cadaver studies, we know that normal fascial gliding is important. And when you have loss of gliding, you create an inflammatory environment, which creates more adhesions, which creates less gliding and creates more pain. So if you can correct gliding in fascia that has adhesions, you can help improve pain. And so that's why we're looking for fascial thickness and that's asymmetric to the contralateral side. So this is an example of the fascia of what's called the serrati fascia. This is the scapula. This is the gliding plane the scapula has to go over. It's shiny. Things slide back and forth across this. And so the serrati fascial sling, which we're going to spend a little time on, is critical for normal scapula function. So this is a panoramic view, spinous process. There's my landscape view across the top. Trap, scapula's over here. I have a rib, intercostal musculature, paraspinal musculature. There's going to be some better images here, but this is kind of get us started. So what's important to understand is I really think this is an important concept. So hopefully this makes sense to you. So here's our Little League baseball player with a normal, intact, healthy pretension of his fascia. Notice that his shoulder is held in retraction in this nice stable motion. So with repetitive throwing 90-mile-an-hour fastballs in college, we start to lose our pretension and our shoulder starts to droop. It becomes anteriorized and it droops down. And then we become a professional baseball player and we take the pretension out of this and the system hangs further and we have less we have more anteriorization. What's important to realize is you lose pretension of the shoulder, you have to make up that difference with increasing strength. And with increasing strength and loss of normal fascial function, you're more susceptible to tendinous injury. And so the point taken is if you're standing on a trampoline, you can't push somebody on solid ground away from you. And so you need this pretension system to throw a 90-mile-an-hour fastball accurately, consistently, without losing power over time. And so here's a little better example. Here's our spinous process, paraspinal muscle. This is the posterior superior serratus. And so this is the fascial plane right here that we're talking about. It goes all the way, it laps underneath the rhomboids and comes all the way back and inserts back here. It's actually a little sling. So here's trap, here's the important element right here with the rhomboid. And so we're going to talk about this for a second. So here's my drawing over that costotransverse joint, rib, scapula, the rhomboserrati fascial sling. So if I could pull that apart so that you could see it better, in my drawing here's the serrati component of this sling, and it comes over and then laps back up on the serratus anterior to the border of the scapula, and then it's going to come back all the way along the rhomboid major or minor, depending on what level you're on the trap above that. So this area is critical for normal, healthy glide and movement of the shoulder. So this is the head. This is the posterior superior serratus. This is scapula, superior border. This is serratus anterior from the first rib. And you can see I've highlighted rhomboid major here. This glides over that. And this is that gliding plane that has to be healthy to have normal scapular motion. So here we are. This is how I scan for this. So I'm doing protraction and retraction of the scapula, and I'm scanning, looking for gliding patterns. And so when you first start doing this, you're like, I don't even know what I'm looking at. But you have to look at a lot of normals, and then pretty soon the abnormals start jumping out at you. So this is all stuff that you can learn to do in your clinic. So here I am protract. This is not the same patient, but this example, almost no motion's happening. There's not much happening. This is a stuck down rhomboserratic fascial sling. So by injecting hyaluronic acid in that, I restored normal motion. And so pretty soon the shoulder is moving a lot better. And so this is the technique that you're going to scan all the way from the spinous process all the way out. This is another example of another patient where I'm running back and forth, assessing the rhomboserratic fascial sling. This is a critical element in terms of your scapular dyskinesis. So I'm just taking it and looking for that. Now, so how do you sort of learn what abnormal is? What I can tell you is that if it's normal, you should have this bunching happen when you hit in range motion. But if this bunching here, or the snow plowing effect, happens immediately, that's usually some adhesions are present. And so in somebody that has moderate movement, but you're seeing this bunching, that's typically telling you that something's not working correctly. So that early bunching versus late bunching pattern is how I describe something wrong with the rhomboserratic fascia. Now, this is an example of somebody that rhomboid has no power. They have no strength in their rhomboid. Well, look what happened. So when I do protract and retract their shoulder, the attachment of the rhomboid minor is not attached. You can see it just slide all the way. It shouldn't do this. So this is what I talk about in those baseball players that have overthrown their shoulder. You see the loss of normal connectivity to the spinous process. So this is an unstable rhomboid in terms of the fascial sling. Here's another example. So this person, this is clear on the edge of the posterior surface serratus, and there is no attachment or very little attachment of this rhomboid to its distal attachment, which is clear over here. And so this is an important element in terms of your diagnosis. This person actually has sort of this dead arm. They can't use their scapula. They can't move their arm. Their shoulder hurts all the time. And the rhomboid just doesn't fire because it has no pre-tension in the system to fire adequately. And then finally, you want to scan and look for these fascial tears off the spinous processes. And so that's what's important. Part of this is you can find these little fascial tears and improve function of the scapula just by, I usually do a test injection with 0.1% lidocaine or 0.2% lidocaine. Don't forget that the rhomboids have interconnectivity to the splenius capitis and a tear of the fascial plane in the neck. Up at this C6 level, I injected this and the left-sided scapular pain went away. So this fascial conduit is continuous to the opposite side. So now the neurologic component. This is going to be the most challenging part of our discussion. Many of you have not mastered brachial plexus, and you may need to spend additional time. But we're not going to be talking about these big trunks of the nerves. We're not going to talk about some of the smaller branches, but for a lot of what we're talking about is these little tiny roots that are hanging out here. So case in point, here's one of these phone apps or IP apps. Look at this. This is all spinal accessory nerve fibers heading all the way down to here. So this is important to be able to identify some of these nerve fibers distally. So you've seen this image before, levator scap, trap, anterior, posterior. This is the spinal accessory nerve traveling deep in this fascial layer. Remember that nerves love to travel in fascia, and this is the dorsal scapular nerve. Be careful, that can be an arterial, but in this patient, the arterial is actually this one, and this is the dorsal scapular nerve. It's easy to see, it's hypoechoic and black like that. It's probably pathologic at this level. So I'm not making a plug for myself. You guys may need some resources to go out. We did AMS Advanced Workshop a couple years ago. If you weren't at that advanced workshop, you're going to need some help. So I did do a talk as part of AIUM. If you're a member there, this is a free webinar. It takes about an hour, I think. And it's part one of a two-part series. That part two is coming up in June. But we talk about how to look at the brachial plexus and the pathologic variation. It'd be well worth your time to take a look at that. So scanning tips for what we're going to talk about today. So if you're short access to a nerve, you're scanning a nerve such as these little small long thoracic nerve fibers in this fascial layer, and you lose it, you're probably now long access to the nerve. Go back, change the angle of your probe, orientate your probe differently, and you may pick up the nerve again. Again, nerves travel through fascia, so if you don't see the fascial layers, then, so here's the long thoracic right there. If you don't see fascial layers, then change your probe position because you're probably perpendicular to the fascial layer, and then try to identify that fascial layer. So, and if you just are lost and you can't follow the nerve, go back to what you know. So just a brief review of the brachial plexus, anterior tubercle and posterior tubercle is C6. Here's C5. You'll have this fascial plane. So this is the middle scalene attachment to the posterior tubercle of the level above. This was the C5 portion. This is her C5 nerve root. And this is the piece coming off of C6. Some posterior scalenes in here as well. But this fascial plane is a highway for dorsal scapular nerve. Long thoracic nerve is from 5 is right here, and 6 is right there. So we'll kind of go over a little bit of that. So your principle is you have anterior, middle, and posterior scalene. Remember the anterior scalene is 3 through 6, and middle scalene is 2 through 7. Posterior scalene is highly variable, but typically 4 through 6, but only in 50% of people. You need to be able to line up your brachial plexus. Realize it's supposed to look like a snowman. So if the C5 is bigger than 6 and 7, you have a problem. Typical alignment is C5 can do anything it wants, but generally they're about the same size, can be bigger posteriorly, but the sort of the true hallmark is 6 is always bigger in the front. So this is the anterior posterior, and it's called Chosnick's tubercle, and then 7 has no anterior tubercle. So if you have this relationship of no tubercle and large tubercle, approximately equal, there you have 5, 6, and 7. So you need to be able to do a comparison and look at the nerve root size on left versus right so you know what normal is. I know what normal is in my head, but when you're beginning to learn this, you'll need to practice doing the bilateral comparison of the left versus right brachial plexus. Anterior scalene, middle scalene, posterior scalene is all this area. This is 7, 6, and 5. And so if you scan enough people in practice, you'll start to pick this stuff up. Now, what's important for the scapula is the fact that this variation creates a ton of scapular pain. I released just one of these today, and it was very challenging. It was an arterial in the way, but we got it released. But this 5 is going completely all the way around. Here it is coming out of 5, going all the way around anterior scalene, just like this drawing. It goes all the way around to lie in the normal anteromedial scalene interval. The problem is this dorsal scapular nerve takes off right here and then goes this way. And so with the nerve being stretched anteriorly and the other nerves being stretched posteriorly with shoulder motion and scapular motion, the dorsal scapular nerve can get entrapped. And so that's a key exam finding, is being able to identify that the C5 nerve root circumferentially goes completely around the anterior scalene. It's seen in 5% of brachial plexus. Here's that same sort of concept. It's going completely all the way around, joins up a 6 to form the superior trunk. Dorsal scapular nerve's going this way, and then a branch of the long thoracic is either going to come off as a common trunk or a separate trunk and form up with the long thoracic nerve from 6. And they always go through these tendon slip intervals. Now, these muscles are much bigger than this, and these intervals are much bigger, but for my purposes of the drawing, it sort of illustrates that the long thoracic nerve picks up all these contributions. So the challenge is can you identify these things to help with scapular dyskinesis problems? So here we are. We're going to scan backward. This is our brachial plexus. There's 6. Here's 5. And notice that this little something comes off of 5 right here. And you'll see it splits into 2. That split is a common trunk of the dorsal scapular nerve and long thoracic. So there's the 2. It splits. This one waits for the contribution from 6. See how that comes all the way to 6? This is going to go all the way back to 5. That's called a common trunk. And this is the mixed pattern of scapular abnormalities that you see. If this nerve's entrapped in the middle scalene and they have an anterior runaround, you'll see entrapment of this, and you'll have a mixed pattern of scapular winging. I see it all the time. And EMGs are almost always normal. It's just sort of a neurogenic problem and not a true atrophy of the muscles. So here's 4, here's 5, here's 6. So in this case, the muscle goes completely through 2 tendon slips that are hypertrophied, and the nerve is being entrapped between the 2 pieces of the anterior scalene. So this is the intramuscular pathway of C5 through the anterior scalene. This is all anterior scalene here, and then it's going to go up all the way around and to find the normal interval. And this is a common variation, well seen at about about 7% of the time. It's slightly higher than the other variation. And there's lots of variations out there. But what's important is that you can identify right there dorsal scapular nerve heading this way. So those are all important in your scanning ability. And you can't use an inexpensive laptop You need to get a good cart-based system to see these things. If you spend enough time, you'll be able to identify the long thoracic nerve regularly, and then occasionally you'll see it's buried within the middle scalene. And if you give this person a heavy weights in their arms, guess what? Scapular winging gets worse. You take the weight out of their arm because the nerve is buried in here. So if you have, shoulder girdle weight, you're lifting something heavy from the ground. So you're trying to do shrugs or cleans. This nerve is getting tugged on over and over and over again. So that weightlifter, I'm always looking for this variation. So that's important to be able to side-to-side comparison identify these. So I did speak earlier about if you see atrophy, the serratus anterior on one side compared to the other, there's no abnormality at the distal insertion, hasn't been pulled off. This is the long thoracic nerve. And this branch right here coming off of it is, I call the posterior branch of the serratus anterior. Other people call it the R1 branch. And why this is important is because this explains superior border prominence. And so in many patients that have that superior border, I have to look for this if I'm not finding other pathology. And so here's the article that changed the world for me. This article shows the superior is innervated by that R1 branch. This is off of C5, and then this is typically C6, and this is typically C7. So if your EMG is only done on the inferior portion, you may get a negative study, even though they're having a scapular dyskinesis or scapular winging problem. So here's the actual dissection of all these nerves. Must have been just incredibly tedious, but this is the nerve coming all the way through it's to innervate the inferior portion. That's all coming off of 7. Here's the part coming off of 6, and then here's the part coming off of 5. And so, and realize in this study, they pointed out that the levator scap was mostly innervated by 3 and 4 in this study. So levator scap abnormality doesn't necessarily always correlate to the dorsal nerve. And in some cases, the C5 doesn't do anything to the levator scap, and it only innervates the rhomboid. And again, they did note some of their cadavers had the R1 branch came from C4, but also C4 did contribute to the dorsal scapular nerve in other patients. So we're back to an old image that we've seen before. Here's the rib, here's posterior, anterior. Spinal accessory nerve will travel in this fascial plane. And after leaving the middle scalene, it typically runs in this plane and dives right through here and then heads deep to the rhomboids or deep to the rhomboids on the medial edge of the scapula. So this can be followed with practice. This is a difficult to obtain image. This is C5. This is middle scalene, posterior scalene, and this is a long axis view of the dorsal scapular nerve traversing all the way through this, coming out, and then if it was a live clip, it'd actually show it diving into the levator scap. This is after I hydrodissected this nerve to free up a dorsal scapular nerve abnormality, and we were able to release all of this by being able to have our probe angle sort of in this angle in terms of looking at C5 towards that superior angle of the scapula. And so these are all variations that I've described on ultrasound. Different variations are very common. The literature on the cadaver side is full of different variations. There's a C4 over the middle scalene, under the scalene, common trunk, around this, completely around anterior scalene. So over, under, through, posterior scalene, it's all been described. And so there's lots of variations, and that's why dorsal scapular nerve is probably the most challenging thing that you'll have to work on. But it's a journey, and it's a journey well worth learning. And I'm trying to raise the bar in terms of the whole nerve component. You can learn these things. If I can learn them, you can learn them as well. So this is what I call a brachial plexus push-up. You cannot identify these nerves with a static study. I'm moving fairly quickly in a short up and down motion, and see how that little thing takes off right there. That's the dorsal scapular nerve. You'll never, ever, ever find that with a slow scan. It's just a dot amongst millions of dots. But with recognition patterning, so we know it comes off and heads posteriorly into the middle scalene in most patients. So you're looking for this little small dot going back and forth, back and forth. So pattern recognition is essential. So if you try to find the common trunk of this coming off of here, scanning slowly, you'll never see it. But if you move quickly back and forth, coming over, I can see the common trunk. I can see this one waiting for 6. Here they are coming together to 5. and then I'll scan back and I'll go back and forth until my eye can see this. And once you visualize it, all of a sudden it starts making sense. And the more you do this with your little brachial plexus scanning is important. Realize that common trunk is seen in about 30%, but in my clinical practice, if they have a sort of a mixed pattern of the scapula, I'm looking for this. I'm spending a lot of time. These are all variations that had been identified coming off of C4, C5, superior trunk. So there's lots of possibilities, but realize that 70% dive into the middle scalene. And so your money's on always looking in the middle scalene first. So the spinal accessory nerve, we have like just a few minutes left and we're almost done. In 50% of your patients, it dives in an intramuscular path through this sternocleidomastoid. So here it is. There's usually a blood vessel with it. Don't get them confused. But this commonly gets entrapped and creates that spinal accessory nerve inferior winging with abduction. And so you want to look for this. So the length of it travels through the muscle is a variable. How steep it enters and how steep it exits are all variables in this. And I see it commonly in whiplash injuries. So don't forget to follow it all the way distally as far as you can. Release this area if you have to. The suprascapular nerve, we've talked about several times in AMSSM. What's important to know about the suprascapular nerve is it comes off the superior trunk and you just need to follow it back and forth. I sort of scan towards the clavicle back and forth, and I pick this up under the omohyoid. And so here is my brachial plexus proper. And what's important is there's this thing called the brachial plexus sheath, and the nerve can get entrapped in the sheath. So this is really an old image that just drove me crazy for years. I couldn't explain what happened there. This nerve, the suprascapular nerve, just comes off the superior trunk in a weird way. It sort of dives around something. It's deformed. And this person just had weakness in the rotator cuff. And so what's happening is as the nerve exits the plexus sheath, it gets deformed, and that's the area what's creating the neuropathy of the supraspinatus. So it's important to be able to follow this all the way distally. Here's serratus anterior. This is this little short thing right here is the omohyoid. But you can see the nerve blows up. It's caught in an adhesion from a shoulder trauma where the nerve blows up back and forth and returns to normal in the fascia. So there's a fascial adhesion restriction that's causing the nerve to be abnormal. So by blowing that all open with hydrodissection, we solve the problem. Don't forget that the first branch off is motor as it dives under the ligament. It takes a 90-degree corner downward at the sphenoglenoid notch, and then it goes under a ligament called the sphenoglenoid ligament and takes another angle. So if you're pulling on the neck this way and the shoulder's going this way, guess what? This nerve does not like this corner. And you see atrophy here. And if you go in, so the angle of your probe is about like this. You go in and you put a needle in and you blow that open and their infraspinatus will come back. And don't forget the axillary nerve. We talked about this at AMSSM a couple times. I scan it in this position, scan down and pick up the axillary nerve going all the way from the quadrilateral space to anterior. And if you hydrodissect in that technique, you should blow open both ends of this to get a good release. So that's it. That's the speedy tour through scapular dyskinesis. It's a journey. All these patients are like peeling layers of an onion off. You have to figure out all the different pieces. You need a sophisticated history, physical exam, and neurologic exam, as well as a comprehensive ultrasound evaluation, and that you can correlate. And then eventually you need to develop the skills to do a comprehensive nerve evaluation. You can learn these skills. You just have to practice. Every time I did a neck ultrasound evaluation for a year, I scanned the brachial plexus as part of it. In the beginning, I didn't know what in the hell I was looking at, but at the end, I started recognizing patterns and fascial planes. And so that's all I have to say, other than answering a lot of questions, hopefully.
Oh my goodness, Dr. Steele, that was amazing and a lot of information. Thank you so much. Yeah, we want to open it up to questions now. So this is Michelle Alexander from Samsung. Please go ahead and post your questions in the chat box.
So do I need to get rid of the screen share to see the chats, or what do I do here? The questions. Remote control.
I'm looking to you. Yep, we're waiting for questions.
Probably scared everybody away. Hopefully not.
Okay, so we have from Frank Nguyen. I did not pronounce that correctly, I'm sure. But you mentioned a variant of the C5 nerve root wrapping around the anterior scalene that you released. Was this done with hydrodissection?
Yeah, it's a hydrodissection, but you need to be really, really knowledgeable of all the vascular components. So there's lots of landmines in there between the transverse cervical and the suprascapular artery. And so once you have a good understanding of the vascular component, and you need to absolutely know where the dorsal scapular nerve lies in the long thoracic, then you can put the needle in there. And typically no two are the same. They're always all different. I did one today, and the approach was quite easy because there was no vascular structure in the way. But here, I'll blow this up if people can still see it. But typically you have to miss the supraclavicular nerves, go over the top of that, and then sort of peel this fascial layer away right here, and then try to walk your needle down into this to open up that 5 interval. And so it can be quite challenging, and realize you better be good at your cervical plexus and your vascular exam before sticking a needle down in here. Okay.
Okay, thank you. There's a lot of questions coming in now. I'll try to be quick. What kind of volume of HA do you use for hydro in the fascia? And this is from Christine Mickles.
That's a really good question. There is no study. I've been looking for the perfect cocktail. I usually use 2 cc's into 20 cc's of my standard nerve mixture, which is typically like 0.1% lidocaine and 0.001 of dexamethasone. I put just a whiff of dexa in it. And then I usually, in 20 cc's, I put like 2 cc's of HA in that, and then I mix it. Realize that when you do injections with hyaluronic acid, you completely lose your visualization of where you just went. So you have to kind of plan out what you're doing very carefully. And I do HA injections into the brachial plexus to help with recovery of the nerve, but you better be very, very, very well practiced in that before you attempt that, because you frequently lose your visualization, and it makes it way more challenging.
Thank you. From Dave Pohl, from a practical standpoint, how long does an initial visit or consult take you? Example, the patient came from Arkansas. Are they in your office for an hour, half a day, or multiple days?
The person that came from Arkansas, the initial visit was an hour-and-a-half length. Includes a comprehensive ultrasound of the plexus and all of that stuff. So I include the comprehensive ultrasound. They've usually sent MRIs and all that stuff before they even show up. We don't even want to see them until we've seen those things. And then between the physical and my ultrasound, realizing that I've done this a lot, so what might take you 2 hours, it can take me an hour when you're first learning. But typically, a lot of my patients, if it's pretty straightforward, it's about an hour. The patient that I saw recently was an hour and a half, because she had cervical plexus trauma, brachial plexus trauma, and scapula trauma. And so that was about an hour and a half. And then they have typically 1 to 2 hours scheduled the following day for procedures. And that's usually, depending on what we do, that's an hour to 2 hours in length. Depending on some of these bigger traumas, there's a lot to do.
Perfect. Thank you so much. Next question, Dr. Steele, thank you for the great presentation. This is from Elliot Huff. In your experience, do you more commonly see a mixed peripheral nerve entrapment pattern, long thoracic, dorsal scapular, SAN, etc., or a brachial plexus entrapment pattern, C4, C5, C6, C7, question mark?
That's a really great question. And what's important to realize, if it's a classic long thoracic nerve problem, they really don't make their way to me, because it's an easy diagnosis. They have scapular winging, they get an EMG, and it shows, oh, the C7, C6 is out. It's the mixed patterns that I see the most frequently, because those are the hardest to diagnose. Nobody knows what's wrong with them. So they have this mixed pattern. It's not really black and white on what it is. And somehow these people make their way to Helena, Montana. And that's, for my clinical practice, that's what I see the most. I think, if you have to look at your own population, and if you're seeing a lot of weight trainers, you're going to see one thing. If you see gymnasts, you'll see another. So depending on what your sport population is, can play a significant pattern into that. The thing that's really common is, so realize that in studies of cadavers looking at brachial plexus variations, normal, what I call Netter's anatomy, is actually less common than a significant variation. So in studies looking at brachial plexus, about 54% of brachial plexus is studied in cadavers have a significant variation that was worth noting. And so from that standpoint, these C5 variations are really, really common in my population, because they've done the gamut. They've had the MRI of the neck, they've had the MRI of the shoulder, they've had EMGs, they've tried multiple surgeries, and nothing's helped. And so, I have a special population, but I think when you're first learning, sort of realize that if you're seeing a mixed pattern, you can't explain the scapular winging pattern by your physical exam. There's probably a C5 variation.
Thank you very much. Last question that I can see so far, and I have to say I don't completely understand it, but it's from Leslie. And she says, what do you hydrodissect with? And if you use different things at different times, how do you choose your injectate, which I suspect is the medium with which you inject?
I pretty much always use D5W plus 0.1% lidocaine. I don't want to block everything. Now, realizing that if you use less than 0.25% ropivacaine, you shouldn't in theory get a motor block. That's not always true. I had that happen on like a 0.025 ropivacaine recently, where they got a motor block, and I was really quite surprised with that. But as a general rule, if I'm playing around with motor nerves, I'll try to use ropivacaine in about 1 cc in a 12 cc syringe, and that's usually D5W. And then again, a picogram dose of dexamethasone. So in a 100 ml bag of D5W, I put in 0.1 cc's of dexamethasone. So it's a pretty small dose. You could barely see it in the syringe. So when I put it in. And then frequently I add vitamin B12. I use like about between 250 micrograms of B12 and 500 micrograms of B12.
Thank you so much. Okay, one more here, I think, and then we'll probably have to close it off. But so Dr. Steele, I am in the military population. I typically see this at the scalene level. Agree that the pain is the last to go. Do you hydrodissect the sand with all your patients with that in mind initially?
Can you read that question again to me? I kind of got lost there.
Sure. I'm in the military population. I typically see this at the scalene level. I agree that the pain is the last to go. Do you hydrodissect the sand with all your patients with that in mind initially?
So this,
and that's from Christina Mishwa.
So if they have that burning scapular pain, you push on the superior angle of the scapula and you reproduce that burning pain, gosh, just release it. It's part of the problem. It doesn't solve it, but it helps their pain. And because you have to figure out why they're winging their scapula there. So that's the, there's a cause and an effect. So the symptom is the burning sensation, but the cause is the winging of the scapula. So frequently, I'll release that spinal accessory nerve across that, and I'll just run my finger down along the medial border of the scapula, and where the pain quits, I'll hydrodissect the spinal accessory nerve as far down as I need to.
Well, we thank you so very much, Dr. Steele. This was wonderful. And if we receive any further questions, we'll certainly forward them on to you. Andy, do you have anything further?
That's it. Thank you so much for everybody for attending tonight. And this will be posted on the AMSSM YouTube channel either later this evening or first thing tomorrow.
Awesome. Thanks, everybody.
Thank you so much. Awesome. And you've got some thanks here. People enjoyed your talk. Thank you so much, Dr. Steele. Have a good night.
Thank you. Bye-bye.
Good night, everybody. Bye-bye.